many of you might be having some of these thoughts up on the screen now. Will I ever regain control? How can I possibly go on a date, attend an outdoor celebration, get a job? I'm afraid to leave home. The bathroom's always on my mind. You're feeling concerned, you're exhausted, you're overwhelmed, but too embarrassed to talk about it. Embarrassment is a real issue of concern for many, as 44% of people who have bladder control problems. Too often, it prevents people from getting the help they need, and we're here to change that. We want you to know a life without limits is possible, and we're here to help you learn how. Next slide. So here's what we'll be talking about. First, we're going to be going over understanding bladder and bowel control. And this will be an overview of how the bladder works and some of the problems that can occur. So how the bowel and bladder work. We're going to also go over the care pathway, which shows the possible progression of treatment. We're going to cover treatment options, and it offers more detail about the many ways to treat bladder control issues. We'll go over Medtronic bladder and bowel control therapy, which is going to cover 2 proven effective options, both the interstim and neurosystems. And then we're going to wrap up by answering your questions. Next slide. So one of the most important things you need to know is you are not alone. I always get patients, telling me that they didn't realize this was as common as it actually is. Overactive bladder, also known as OAB, is extremely common. For example, it's more prevalent than vision problems and diabetes, which are 2 conditions most think of as being extremely common. You may be asking, if it's so common, why haven't I heard about it until now? Well, many people with OAB self-manage by drinking less, they wear pads, they'll restrict social activities, they're embarrassed. At the same time, physicians don't realize how embarrassing it is to talk about these bladder control issues. So we as physicians don't ask, and patients never bring it up, so it stays hidden. Bladder control issues can happen to women and men of any age. And although your risk does increase as you get older, it's not something you should accept, ignore, or leave untreated. If ignored, these issues can raise serious risks, not only for your general health, but for your self-esteem and your confidence as well. And one thing that I really want to emphasize is that incontinence is not a normal part of aging. I can't tell you how many patients I have coming to me saying they expected it to happen as they got older because it happened in their grandparents, their parents. It's not. They're not a normal part of aging. Do these things sound familiar? Going more than 8 times a day, getting the have to go now feeling, you plan activities around the bathroom, you have to monitor how much you drink, you have to use pads to control leaks. If these sound familiar to you, then we need to do something about it. The bottom line is OAB can be a very embarrassing condition, and it can have a significant impact on quality of life, but it's not something you have to live with. Next slide. So, how does bladder control work? So to understand what your body is saying, it's important to first know that communication is critical to how the bladder works. Bladder function involves the coordination of the brain and muscles through our nerve signals. As your bladder fills with urine, nerves tell your brain that it needs to be emptied. Research suggests that the bladder control problems are linked to poor bladder-brain communication. And what I want is for you to keep these things in mind, keep these points in mind for later, because we will be talking about how various treatments differ from one another and how they target different pathways that we just discussed. Next slide. We're briefly going to go over bowel-brain communication as well. And the reason why is because interstim is actually FDA approved for fecal incontinence as well. So we'll briefly touch on it. Bowel and brain communication is just as essential for bowel control. Bowel function also involves the coordination of the brain and muscles through our nerve signals. The digestive system works by moving food through the intestines, which usually takes about 24 to 72 hours. Muscular contractions squeeze the food through the different sections, and each section is separated by bands of muscles or sphincters, which act like valves. As the rectum fills with waste, nerves tell your brain that it needs to be emptied. and your brain tells the anal sphincter muscles to relax so that that can happen. I want you to also keep these bladder and bowel brain communication points in mind so we can again discuss the different various treatments and how they'll affect different parts of the pathway. Next slide. So where do these communication problems come from? There's many potential causes. Oftentimes, incontinence, both urinary and fecal, can be idiopathic. Some causes are as simple as what we eat and drink every day or the medicine we take. Some are related to life events like childbirth and health conditions. Or maybe you had an injury to your pelvic floor or you had surgical complications. Next slide. So in general, we're going to go over 3 different common bladder control problems. The first will be stress incontinence. We'll look at urinary retention, and lastly, overactive bladder. Let's take a closer look at each of them in turn. So what is stress incontinence? Stress incontinence is typically due to weakened or damaged pelvic floor muscles. It occurs when there's an increase in pressure on the bladder from activities such as coughing, laughing, sneezing, or lifting that results in leakage of urine. We associate it more with physical activity. So this type of incontinence can be managed conservatively with pelvic floor exercises or physical therapy, but typically it requires surgical correction if conservative measures fail. Urinary retention happens when you can't tell if your bladder is full and you are unable to empty your bladder. It can be incredibly frustrating and may also require the use of a catheter. It may or may not be caused by physical obstruction, so you may either have obstructive or non-obstructive urinary retention. This could be due to an anatomic obstruction, such as an enlarged prostate in males, or pelvic organ prolapse in females, or it can be due to idiopathic urinary retention, which we sometimes call your underactive bladder. And lastly, we'll discuss overactive bladder. It's a syndrome characterized by urinary urgency, with or without incontinence, as well as urinary frequency. Urge incontinence is a sudden urge to go to the bathroom, which also results in an actual loss of urine. It can happen day or night, and a lot of times this is how I ask patients about it and differentiate between the two, because I'll ask them, are you leaking at night? Because usually when patients leak at night, it's due more to urge incontinence. Urinary frequency refers to frequent trips to the bathroom. If you have OAB, you might have a variety of overlapping symptoms. It's our job to work through these symptoms to help you find a therapy that fits your needs. Lastly, what is chronic fecal incontinence? Most of the time, bowel incontinence only happens during a bout of diarrhea. But with chronic fecal incontinence, this is different. It's a recurrent condition, meaning it doesn't go away. People who have this may be unable to resist the urge to defecate, which happens so suddenly that it's difficult to reach the bathroom in time. This is called urge incontinence. The same way we label urge urinary incontinence, we see urge fecal incontinence. There's another type of fecal incontinence that happens when people aren't aware they need to defecate. They can't feel it in the normal way. So this we label as passive incontinence. And fecal incontinence may also be accompanied by other bowel problems such as diarrhea, constipation, gas, and bloating. The good news is OAB is a treatable condition. So can fecal incontinence be. Right now, we're going to focus on some of these treatments and find out if something is available for you. There are a number of steps involved, though, in finding the best treatment for you. We have conservative treatments. We have more advanced therapies as well. We're going to take a look at all of these. And just keep in mind, it's really important to remember that every person is unique. What works for you isn't going to work for someone else, and vice versa. Everybody kind of decides what treatment is best for themselves based on what they want, what their goals are for treatment. So the first thing we usually turn to, because it's the easiest in some ways, is lifestyle changes. In other words, these are behaviors that you can use to help improve your situation. It might mean changing what you eat and drink, decreasing caffeine intake, getting more exercise. Weight loss is a great way to improve some of your bladder symptoms. It might involve bladder retraining, which means delaying going to the bathroom and suppressing your urge to go immediately, as well as timed voiding. So when you do timed voiding, you actually stick to a time schedule when you're voiding throughout the day. And this is a way to retrain your bladder. Pelvic floor strengthening is also super important. It can be done repeatedly contracting and relaxing the muscles of the pelvic floor. This can be done on your own at home, or a lot of times I send patients to actually work with a pelvic floor physical therapist. These exercises are most commonly known as Kegel exercises. What's important to keep in mind is that these lifestyle changes, although they're the easiest to do, they're not always going to work for everyone. They may not work very well or at all in some cases. And that's why we have other treatments. Our next line of treatment are medications. So when lifestyle changes fail to deliver the results you want, we'll usually add oral medications. It's the next step. These medications work on the bladder muscles, not the nerves. They act by relaxing the bladder muscle. They can help control symptoms, but they do have some drawbacks. They can cause dry mouth, blurry vision, constipation, hypertension. You do have to remember to take them every day. That's another thing. And lastly, they're not always going to work. They're just not as effective. In fact, some data suggests that 72% of people stop taking their medication after 6 months. And one important point that I always like to bring up is that we do have some older OAB medications that can cause some confusion and memory loss. We have a large study that was done recently that was funded by the National Institute of Aging. It was published in the Journal of the American Medical Association, and it's been shown that elderly people taking anticholinergics, which are our older class of OAB medications, are at greater risk for developing dementia. So I'm always very cautious when prescribing these medications, especially in my elderly population. Next slide. Next, we have injected medications such as Botox, which treat OAB temporarily by paralyzing the muscle, and they require multiple ongoing office visits. So just like oral medications, injected medications focus on the bladder muscles, not the nerves. The Botox is injected directly into the bladder via cystoscopy, which is a camera in the bladder, to paralyze it. So this is why the treatment doesn't address the actual communication pathway, the bladder-brain communication pathway that we talked about earlier. It's directly acting on the muscle. If you use these injections, you will be at risk of UTIs, so urinary tract infections or bladder infections. And in some cases, you may end up having to catheterize yourself. These Botox and injected medications are typically only as effective as oral medications. And this way may be why so many people quit after just 2 months. So if conservative treatments don't work for you, there are more advanced therapies for both bladder and bowel control. And so, for bladder control, Medtronic offers the interstim and neurosystem. For bowel control, they offer interstim. And we're going to go over some of the trade-offs involved with each of these options. The Medtronic neurosystem is a form of percutaneous tibial nerve stimulation. I like to describe it to my patients as acupuncture for the bladder. It stimulates the tibial nerve, which is located just above your ankle. The goal is to restore bladder function, achieving a measurable reduction in your OAB symptoms. Each treatment session lasts about 30 minutes and takes place in one of our offices. You start with 12 weekly sessions, and then you move on to monthly maintenance sessions. So the good thing is very minimally invasive, however, very time consuming. The second system is going to be interstim. This is a second neuromodulation system that Medtronic offers. And this works both for bowel and bladder incontinence. So this therapy provides relief by gently stimulating the sacral nerves, which control the bladder. It helps correct the bladder-brain communication pathway and restores bladder function. So really the only one aimed at the actual pathway and regulating the nerves. It's clinically proven to reduce or stop accidents, A test lets you try the therapy to see if it works for you. And if you and your doctor move forward, then a small battery implant is placed just below the skin in your upper buttock. There are recharge-free and rechargeable devices available. Most recently, the FDA has approved Medtronic's newest battery, which is recharge-free and can last up to 15 years. The side effects are minimal. It includes pain, infection where the implant is placed, and migration of the leads, which is rare. So unlike some bladder control treatments, this therapy lets you try it first. It's like a test run. There's no long-term commitment. You try it first with a simple test that's going to start at your doctor's office, or sometimes it will be done in an outpatient surgery center. A lead, which is a thin wire, is inserted in the upper part of your buttock. The lead attaches to a small external device or battery that's worn discreetly under your clothes. You stop, start, or adjust therapy with an easy-to-use programmer, and you basically go about your regular activities for 3 to 14 days, and you'll keep track with the voiding diary to see if your symptoms improve. At the end of the test, you'll have a much better idea if this therapy is going to deliver the relief you expect. Usually, we move on to implanting the permanent leads and battery in the operating room if patients note greater than 50% improvement in symptoms. So, what makes somebody a good candidate for this therapy? If you have significant symptoms of OAB, like urge incontinence and urgency frequency, if you have non-obstructive urinary retention, if you have chronic fecal incontinence, or if you've already tried many different kinds of lifestyle changes, behavioral modification, bladder training, pelvic floor physical therapy, and medications, and you're just not happy. Most importantly, you're just not getting the kind of relief that you want, and you want to get back to living your normal life. That's another reason you should do this. So if this sounds like your experience, the first step is typically going to be an evaluation. So we know that the interstim system definitely offers proven results as well. It's the only therapy that provides better relief than medications. We know that there's about 84% satisfaction amongst those who use it. We see 3 times greater improvements in quality of life compared to medication. And 76% of people achieve success with sacral neuromodulation compared to 49% for medications. So this is an example of, it's a patient testimonial. Unfortunately, it's difficult to show you the video virtually, but this is a lady who, her name's Sarah, basically saying, I'm getting back to doing the things I love, and that means everything. And I've definitely experienced similar patient testimonials. Patients are just happy to be able to live their life. They're not stuck at home anymore. They're not requiring pads or even diapers. And they're happy. They can actually leave their house. And so that's exactly what we want for you. So that was pretty much it. We kept it short, sweet, and simple because we really want to give you an opportunity to ask questions. I want to thank you for listening. If you'd like to discuss one of these therapies in further detail, please contact our office. I'm really happy to meet with you and go over more details about what treatment would be the best for you. More than anything, I want my patients to be happy, and I want them to be dry. So right now what we want to do is just open up the discussion. We're going to give you an opportunity to ask any questions you might have. And I think, Michael, you're going to be kind of in charge of that, right?
Correct. Yes. I'll be reading these as kind of they come in here. So I'll start with the first question. Will it help someone who has a prolapse?
Oh, that is such a good question. So if you look at the data, these are 2 independent diagnoses and conditions. So I see a ton of women who have prolapse who don't have urge incontinence, and I see a ton of women who have urge incontinence who don't have prolapse. So they're independent of each other. However, what I will say is that a lot of women who have severe enough prolapse do not empty their bladders very well. And when that starts happening, the bladder starts accumulating a good amount of urine, which can then lead to urgency, frequency, which does kind of mimic overactive bladder. So it becomes very confusing. And when we do operate on those women and correct the prolapse, we find that their urgency and frequency actually gets better. Did they have overactive bladder to begin with? Maybe, maybe not. But really, these specific therapies we discussed today are going to be more for your patient who has actual overactive bladder or urge incontinence, not necessarily due to pelvic organ prolapse. I would never put in an interstim device in somebody who has pelvic organ prolapse. That's just not going to be the correct treatment.
All right. Question 2 here. Can you see the device when it's been implanted under the skin?
No, we usually try to put the device just deep enough that you can't see it. You obviously, if you touch the area, you will feel it. But we put it deep enough that you really can't see it. Everything is going to be inside. So there will be nothing hanging out of your body. And usually it's not protruding out at all. It's deep enough that you can't see it.
All right, then here, insurance. Will insurance cover the procedure / device?
So that it's obviously insurance dependent. We usually always request a prior authorization before proceeding. So we would never offer it to somebody or actually go through with the actual percutaneous trial, which is that initial stage, unless we knew the insurance covered it. And right now in California, we are in the process of trying to get it covered for all our Medi-Cal HMOs, which is a work in progress, and we're really hoping we can turn that around. But as of right now, I know that Medi-Cal HMOs are not covering interstim.
Okay. Can I get an MRI with the interstim therapy?
Yes, that's the great thing about Medtronic's new devices, both the recharge-free and the rechargeable batteries are completely MRI compatible.
All right, here. Do most of your patients get good results from the test?
Yes, I find that the majority of my patients, if they truly have overactive bladder, they're going to do better with one of these more advanced therapies than they will with medication. And so I don't push my patients to do it. I let them decide. I always feel very strongly that patients should decide what they want, especially because this is a quality of life issue. But I will say the majority of my patients definitely think that this works better than medication. Are all my patients 100% dry? No. But that's just also dependent on how severe you are. And you have to also keep in mind, if you also have stress incontinence, interstim is not going to be a treatment for stress incontinence. So that is something that will have to be addressed separately. And so sometimes patients get confused about that because we're treating two different types of incontinence. And a lot of women expect the stress incontinence to get better. And that part of it, unfortunately, won't. Only the urge incontinence part of it will get better. The urinary retention patients, those, they tend to do better. They don't always empty completely. They may go from having to catheterize, maybe they were catheterizing 4 times a day at once to once a day. So it's an improvement. I don't ever promise anybody they're going to be able to void completely normally or completely empty their bladders. So that's a little bit more hit and miss, but for the most part, you still see some degree of improvement.
Let's see, can it work for both bowel and bladder at the same time, or is it one or the other?
No, absolutely. I've had tons of patients who I've placed it for both conditions, and both improve. So that's the really nice thing. So when I have patients that have urge incontinence and fecal incontinence, I always kind of let them know that, this is an option that can treat both. Whereas if you were to choose Botox or even the PTNS, you're not going to get those same results for the bowel incontinence. It's really only going to be the interstim that can treat both, and it will treat both at the same time, which is nice.
If I've already tried Botox, would interstim work on me?
Yeah, so the nice thing is that, if Botox didn't work, there's no reason why we can't try interstim. If Botox didn't work, it doesn't mean that interstim's not going to work. In fact, that's what we do. If we try one, if one doesn't work, we move on to the next. And so even if you've had Botox in the past and it didn't work for you, it doesn't mean that interstim won't work. It might work completely differently. It might be the exact, solution that you needed. So yeah, I always let patients know that just because one treatment modality doesn't work doesn't mean we shouldn't try another one, because it very well may work.
Okay, here, this one is, what is the test process like?
So the test process it's pretty simple. And it involves usually what we call a percutaneous trial in clinic. If the insurance doesn't approve it to be done in the clinic, then we usually will do it in the operating room. But the majority of patients get done here in my clinic. We have you come in. You'll basically be with both Michael and myself. You are face down. We will numb the area where we're going to put the leads in. And basically what we do is put in some temporary leads that are tunneled under the skin, that go down towards the nerves. And you will, once those are in, it can take maybe anywhere between 15 minutes to half an hour. We will secure those leads to an external battery. And then you'll go around with an external battery. So you will have like a gauze dressing on your back for about a week, but you'll just kind of pay attention to what happens. You'll keep avoiding diarrhea, keep very close tabs on how frequently you're going, how many leaks, how many pads you're using. You really want to be able to describe the difference between before and after when you come back to see me in a week. And at that point, you will let me know, did I see more than 50% improvement in my symptoms? If you have, and you want to move forward, the second stage would be putting in the permanent leads and batteries. So at that follow-up appointment, I take out the temporary leads, and then we decide, if it didn't work for you, then fine. We took the leads out, no harm done. If you do decide you want to get it done, then we move on to the second stage where we'd actually put in the permanent leads and battery, which is done in the operating room.
If I've had a sling operation, will this therapy work for me?
Yes. So it all depends on kind of what diagnosis you have. So, for example, if we see that the sling is working really well for you, there's no issues with incomplete emptying, there's no concern that the sling is too tight, causing you obstructive retention. And we really think that you just have developed de novo urge incontinence. You have just become, your bladder has just become overactive. There's no concern for obstruction. Your sling is in a good position. Maybe you don't have any more stress incontinence. You're happy from that standpoint. Then yes, interstim would be the perfect option. Now, if you come to me and you've had a sling put in and you can't empty and you had issues peeing after you had your sling put in, well, that raises a little red flag to me that something was not done correctly. Like maybe the sling was put in too tightly. Maybe there's something wrong with the actual mesh. That would have to be worked up further, because in that situation, you have now fallen into the obstructive urinary retention category. You would no longer be a candidate for interstim. So we only put in the interstim if you have either urge incontinence and you're emptying well, or you have non-obstructive urinary retention, where we know that there's not some kind of anatomic or mechanical obstruction causing you to be unable to empty. So the workup would have to be done. But the short answer is, if you have a sling that's in proper position, that's working well, and you develop urge incontinence, or you had it even before you got the sling put in, then yes, you would be a good candidate to have interstim.
All right. If the test works well for me and I get the implant, what is the recovery like?
Recovery is easy. We made one small incision, and that's just to put the battery underneath your skin. So I usually have patients maybe just no heavy lifting for a couple weeks so that area heals and the incision doesn't pop open. No bathing in a bathtub, no jacuzzi, no pool. Once I see patients in a couple weeks, by then incision's usually fully healed, and after that you're pretty much free to go. So the recovery is not bad at all. You go home the same day. You are under general anesthesia for the procedure, but it's usually less than an hour and a half at the most. And then you go home that same day. I never give patients, heavy duty pain meds. Everybody usually does fine with just some Tylenol and ibuprofen over the counter.
Okay, looks like I have two more here. Are you able to control the system, the therapy? If so, how, or how does that work with?
So you will be sent home with the programmer. It allows you to not only change the different program, but you can actually change the amplitude, which will change your sensation. You will feel a little bit of stimulation. We usually want patients to feel it down below. Not painful, almost to the point where you stop feeling it at one point. But if you're not getting the results you want, Michael or myself, we can usually help you adjust the settings so that we can get better results. So the good thing is you'll always have the support. You're never going to be expected to adjust anything on your own. But the nice thing is you do go home with a controller that looks like a cell phone, essentially, where you'll have the capacity to not only change programs, but change within a program, change the setting to adjust your stimulation. And that'll allow you to hopefully get better results if that's why you're trying to change it.
All right, and last question here. I saved this for last. I thought this was good timing for it. If I want to talk about getting an implant, what are the next best steps for me to take?
So for those of you that are already established patients, you just need to have a follow-up with me. And, next time you come, we'll go over everything. I will show you a video. I'll show you what the device actually looks like. I'll give you some educational handouts so you can educate yourself and go on the Medtronic website to read more about interstim. If you are a new patient and you're interested, you will need a referral from your primary care physician to see me. And then once we have all the necessary information, we will go ahead and schedule your appointment.
Okay, super. That was the last question. Thank you everyone for jumping on tonight. Dr. Sevilla, thank you for your time, and
Absolutely.
Anybody who is interested, like I said, I hope you got the information for the office in the presentation, and we look forward to seeing you.
Thank you. Thank you so much. Appreciate it. Bye.